I think it's very strong. I mean, we have a paper published last year in Lancet Oncology that in the title of the paper, it says pan cancer, which is as true as we can make it. It wasn't every cancer we tested, but it was 7 different disease sites and 11 cohorts. And I think in every cohort we've tested, we've seen a signal to suggest that a genomic-based radiation dosing strategy outperforms a non-genomic-based radiation dosing strategy. And I think in some ways that seems quite obvious. If you think about an analogy I'd like to use, which is the invention of the CT scanner. So you think about how radiation therapy was delivered before we had the CT scanner, before we knew about 3-dimensional anatomy of our patients. We were dosing patients with radiation therapy based on a 2-dimensional view and therefore assumptions about how the tumor looked. But the moment that we measured the 3rd dimension, we realized sometimes we were missing. Sometimes we could have had a much smaller field and done much better. All of a sudden we saw an opportunity to do better and we moved forward quickly. And I think what I've seen now in looking at these genomic data over many, many, many cohorts is that maybe it's not perfect, but it is an immense step forward. So, I think when we move from X-ray to CT, CT is not a perfect version of the 3D anatomy. It's not nearly as good as MRI, for example, but it's way better than not seeing any of the 3D anatomy at all. And I think what we're doing and what I suggest we're doing here is opening up a new dimension of biology into our dosing strategies. And I think that should apply across all cancers. I think in the future, I'd like to see disease-specific genomic classifiers. But right now, with 15 years worth of data, the one that we're using and have validated across most cancer sites, I think is a sensible way forward, helping us then to learn going into the future.